Well, I'm so delighted that you're here today. I know I'm doing kind of a massive infomercial for this project I just got to be part of. It's called Embodied Books Class, and it was done at the Two Rivers Gallery by Darian Goldenstahl, and it's 5 sessions. And I want to kind of like the other videos I've made, as you know, Carlene, or Steven Spielberg, you know that they were more about my own directives, right? And so I wanted to sort of advertise. This woman put together this fabulous kind of project where she brought in the Two Rivers Art Gallery as a beautiful space that has the resources and safety and locked doors and all this stuff because it's at night. And she advertised it, and she found herself 10 people who were going to talk about a medical condition, medical experiences, and do some art about it. And she's got 3 directives, which I'll guide you through here in a minute. So 5 weeks, 10 volunteers, 3 directives, Two River Gallery, put together by Dr. Darian Goldenstahl. She has from my understanding, she has a master's degree in fine arts and a PhD in some kind of medical interdisciplinary background. So what she's doing is this wonderful dovetailing, harmonizing of 2 bodies of knowledge. And one of the things she loves to do is make artist books. And that's a whole thing. That's a whole, let's say, genre of display. There's paintings of canvases, there's jewelry, there's embroidery, tapestry. There's so many ways that people can express their smart creativity. And one of her things is making these amazing different book responses. So some of them are big, some are little, she has one where she uses video discs and puts them together with the image of video discs. Please go to her website and you can learn all kinds of things that she's done. So I wanted to talk about from the participant's perspective. So if you are using art-based research or you're using creativity to express something in the world, all the social work students I work with, gender studies students I work with, this could be an example of what your participants might go through, and you have to anticipate that in advance. So 10 participants, 5 weeks, Two Rivers Gallery. She also had to put together a whole written plan and submit that to the ethics board at UNBC or elsewhere. It's always pretty much a similar process. And then, so she had to wait, I'm sure, 2, 3, 4, 5 months to get that all back and perfectly refined. So in that kit she'll have, and it's here in my binder, she gave this to all the participants, an explanation of what she's doing, why she's doing it, how she's doing it, who she intends to use this for. We had to sign consents to have our art involved in some way. We had to sign consents that we understood what we were being asked of, and so on. So again, when you're doing art-based research, some people have this idea, you get some people to draw some pictures and you're done.
Yeah, there's no process or method.
Yeah, and so you have to have a very clearly expressed plan, rationale, involvement, all this stuff. But at the same time, when you're doing art-based research, you also have to leave lots of room for people to be creative, imaginative, responsive in their own unique way. Because that's the research. That's your data. So if you've too tightly closed the doors before you even start, you're not going to get fresh, new, imaginative data. Right? If you're asking people yes-no questions, there's no art to that.
Yeah.
Right? So she's asked people to do 3 things. One is, and she guided us through this process, and I couldn't kind of get it. I don't have the spatial relations gifts in my brain. But she asked us, and I'm going to show her little one here. She asked us, the first directive was to make a little book, a little booklet, and you have to cut it a certain way and fold it a certain way, and then it opens. So she asked each of us to do I am, and then to talk about, I am a person with MS, or I am a mother, or however people wanted to answer that question. So they made these adorable little booklet things, right? Now here's another special thing that she put into this research project. Students in an MSW program thinking of using art-based research ponder this. I thought, well, that's a big ask. We will give all the art to her when we're done. that's kind of a unique ask. I'd never heard of anybody doing that, because usually what you do is you ask. When I've done these kind of workshops or events, I have maybe a consent to say, can we take a picture of your art? And people can say yes, no, right till the last minute. Or they can even say, you could take a picture of my art, but only from this angle, so that the words aren't there. We give them a lot of freedom to choose how they may allow us to take a picture. Sometimes we've said we don't want to take a picture of your art because we know it may be too self-disclosing and maybe not right to do that, right? Would you be okay with us taking a picture, and I've done this more than once, where you're in a circle and you just put your shoes in. And if you feel your boots might disclose who you are, like if you're a person who wears red cowboy boots or something, you could even take your boots off and just have your socks. So we can have a collective picture that represents us, right? So I was quite surprised and startled by this ask. So we each had to make a thing like this, and I'll just show you how. I won't show you because I don't want to disclose anybody's personal stuff, but each person made a similar kind of thing, and were asked to make 11 others to give away to the group. So again, I was kind of surprised. That's a big ask, because sometimes people go, I want to make my thing. This is perhaps the difference between art therapy and art-based research. In art therapy, you would never think to say to the person, I'm taking your art when you're done. It just is unheard of, right? But in art-based research, you may ask that. And what is she taking your art to do? So, of course, she had to have a rationale for why am I taking your art. Because she's using all of this. This is one of her endpoint goals. This material that we are making as people who are participants in the healthcare system, who've used services, who have symptoms, MS, head injury, etc. What have we felt and thought that we would like medical professionals to know? So she's taking this to doctors becoming doctors and nurses and so on in the medical profession. So I think that is really a juicy, what's the point? A lot of times students doing their MSW or their gender studies MA, they're kind of, what's the point? Why am I being asked to do all this? Because your research ideally is going to communicate something to someone who needs to know that information. And this is a beautiful synchronicity or harmonizing between what are the things we didn't get doctors to understand and doctors who are wanting to learn and be better. It's quite beautiful. Right? It's worth it.
Yeah,
it's worth it. So each person not only made these little booklets, and I'll just really quick so you can't read them, but each person made the booklets and made extra for everyone in the room, one for themselves to keep and one for her to use to show. Very, very interesting, very unique, very distinctive. Now, I can talk a lot about mine. I never did get that spatial relations folded and then folded again and then to the left and then cut a hole in it. I didn't succeed with that. So, I did my own thing. So why do I tell you this? That as a researcher, you want to make sure you have a perimeter, a boundary, a plan, and limited choices. But you don't want to be too tight that the person or persons who have something a little to the edge, let's say an anomaly, an outsider, in your research, you don't want to make them feel horrible so that I'll go along with everybody or else I have to leave. Because those people, not being boastful, but sometimes those people are the people who are the most interesting, who have the most substantive thing to say to you. Right? I've done workshops like this that were based in research with an amazing nurse from the university also, Delphina, and we did it with people who have had head injuries or the care workers, loved ones of the people with serious head injuries, right? So their stories are incredibly diverse. If someone had a head injury when they were 10 versus when they were 50 versus when they were 70, if someone has a ton of money and they have a big family, it's an entirely different thing to have. Let's say you have a head injury at work, you're going to get compensation, you're going to get respect and so on. And if you have a head injury from skidooing while you were on a drunken binge, you're not going to get any money for that.
No.
Right? But at work, so there right away is a difference. And you want to, when you're doing research, you want to always be able to create a space to capture and find the diverse range of whatever's going on. So she made me feel safe, and kind of after a few minutes of talking to me, she kind of, do your own thing, son. Do what you need to do. Be you, right? So my story, as some of you have seen it, the other videos, is my husband in 2014, July of 2014, was diagnosed with cancer. So that's part of why I was pulled into this. I thought, well, this will be interesting for me. What do I get out of it is to process a little bit more of my grief with other people who have confronted this kind of thing. I also was very inspired and motivated to talk about, oh, this gives me a chance to feed back to the medical system some of the things I wasn't happy with or didn't feel were in my husband's best interest. Mm-hmm. So she asked us in our little booklet, I am, go wherever you want. So I am his wife, cherishing him, and it's unbearable, the ruination and the grief, grief, grief. So this was what my little booklet ended up being. Instead of folding, I can't get with that, so I just did my own thing. And made this little booklet that doctors and nurses will get to see at her art display about my experiences as his wife and his advocate. So, this is the theme I wanted to take up, to process more of my grief and to vent my anger. So I'm giving you the big picture there. 5.5 years of him having cancer, diabetes. We beat the cancer. He then got cancer again, had a chunk of his throat taken out. He had his, everything between here and his butt taken out, and he had to have a pouch, and he had to have a stent in his penis for urine. So this involved a lot of stuff. And then he had a third attack of cancer. In between it all, he'd also had pneumonia, cellulitis. He'd had sepsis, various infections. Towards the end, the September of his last year, he was flown to Vancouver Hospital to have surgery on his heart and a vein here because they had gotten plugged up somehow. It was emergency surgery. It was horrific for both of us. Mm-hmm. So all this is going on for 5.5 years. And that's my medical location here, as I am his wife. Mm-hmm. And I also have osteoarthritis, I have headaches, I have clinical depression, I have ulcers, I have high blood pressure. All of that was my pre-existing before July of 2014, when he first got his diagnosis. So I'll tell you another thing about how the research, wanting to have everybody fit their story in. So I have pre-existing healthcare conditions. I'm trying to support him with love and compassion. I'm also the breadwinner. I'm also a member of a family of two, him and me, right? So some of the people in the circle giving data for this research, they have a family, they have a mother, they have grandmother, they have a spouse who's working full time. So that was my symptom and my issue. I'm working full time, trying to love him and care for him full time and be his advocate. So that's kind of the nutshell of this story that her research, I believe, should be able to capture. So everyone made these. They made enough to keep one themselves, give one to her, and give one to all the other participants. Mm-hmm. So that's a very unique thing to build into your research project. I'd never seen that done before. Yeah, so that's very generous and extraordinary in my attention, right? So she had us set up with her, again, if you're a master's student preparing your research project. So there's all of that you have to think about. Catching the whole array of knowledge, doing your research ethics board, the time frame of all of that. What will it be like to be the participant? Why should they do this for you? This is, why should I, as a participant, I don't know her from dirt, and she's asking me to go for 5 sessions at night. And in my own case, I'm walking there at night through a scary area of town. Mm-hmm. And I'm coming back at 9:30 at night. So that, again, was a big ask. Sometimes, and I would advocate it, if you really need to think about your potential research participants. Do they have transportation? Will they need money for childcare? Will they need you to come and pick them up? Are you offering this in a safe place? We have to think about that from the participant's perspective.
Yeah.
Right? Not necessarily anybody else's, but from them. Be deep in your empathy as a research planner and designer about that. So, I have wonderful things to say about this whole experience. I've learned a lot. I wish you to ponder, how might you do something like this? So, we have our first little booklet. The second session, she talked about us going further. I won't go into too much detail here, but about us going further with our research thing. And maybe the camera needs to come a little bit over here to make sure you're capturing me still.
Oh no, you're still in frame.
Still in the frame. I'm still in the frame. So, by my own appetite, which she left me the space to do, I ended up making 3 expressions. I wish to talk about my husband's perspective, my perspective, and the medical industrial complex perspective. So 3 locations. And as I went deeper into pondering all this, I realized I couldn't just do one. That's the point. That's the point. The medical profession, each of the people there, take it from their own exclusive and solitary perspective.
Mm-hmm.
That's my point. That they didn't see it from our perspective. Right? And I'll tell you some stories in a minute. So this is the book of the medical profession here, a medical industrial complex. So my husband had a doctor for his diabetes, a doctor for the cancer, a doctor for, or specialist or a voice or a nurse from the chemo, from the radiation. Mm-hmm. The surgeries were each done by different people. The stent has to be changed every 3 months for 5.5 years. Every 3 months he had to go back to have surgery to take the straw out of his penis, because it went from his penis to his kidney. And the worry was, if it's left in too long, the body grows around it and it plugs up. Mm-hmm. So you have to put in a fresh straw so the urine can move out. So imagine knowing you have this horrible pain. That's incredible pain. Mm-hmm. Your penis, and into your kidney. I can't even wrap my mind around how much pain that caused him. He'd have to go, and he knew for the rest of his life he would have to do this. In addition to all that, he was allergic to pain medication. So his story was unique. This is the point I want everyone to get in the room. Humans are not burgers at McDonald's. We're not a bucket of chicken at Kentucky Fried Chicken. We're not a bagel from Tim Hortons. Humans, every story is unique. The sequencing of it, the pain, the body, the allergies, the geographical location, the access to resources, all of that. The point that I felt with the medical profession was they treated us as a burger in many cases, not all. And by burger, I don't mean that they chose to be disrespectful or unkind. The way the medical industrial complex is structured. So, for example, doctors are paid for 15 minutes. And I know that. And I know that in the 16th minute, I might be starting to piss this person off. In addition to pissing off this doctor or specialist, I'm pissing off the other 12 people in the waiting room. I'm conscious of that. So was my husband. So what I did to express this is it's all white, it's all kind of the same. They're looking at us from 15-minute increments or whatever. And this is a heavy white rock, and it's duct taped together. And then, just to give you some more words from that, in addition to the specialist, the diabetes guy, the surgery person, we also had the ambulances multiple times being called by ambulance. I would have to call an ambulance. We also had the pharmacist to engage with, the emergency staff, because the ambulances would put him in the emerge, and then we'd have a different doctor every single time. And I understand why that happens, but I'm reminding you medical professionals, from our perspective, you're an outrageous array of completely different people, different disciplines, so on. And here was also a big shocker that I would wish people to get. We didn't realize till we were about 2 years into this experience that the medical system doesn't use all the same databases. We had assumed when we tell the diabetes person this and they have our medical card number, that they would type this into some computer that would be available to our family doctor or to his heart specialist or the stent guy. No. No one told us that. So then the doctor who told me this, he said, it's up to you, speaking to me, the wife, who has a full-time job, in addition to my full-time job caring for my husband, in addition to some of my own healthcare things. The family doctor number 3 in this journey, said to me, you were responsible for bringing this information from one specialist to the other from the hospital, and so on. Oh! 1, I didn't know that. 2, it seems kind of archaic. And 3, can't y'all do that amongst yourselves? Because I don't even know what to communicate sometimes. Okay? Mm-hmm. So he told me you should take notes. Me, the wife, should take notes. Okay. So these people weren't consulting, and sometimes they would drop the ball. So we would have, let's say, 2 specialists, because they're not integrating. One appointment would be at 8:30 in the morning, and another appointment would be at 4 in the afternoon at a different place. So that's 4 taxi drives or more, costing us $100 or more. Also, my husband is exhausted after 1 visit, right? And then they would say things, well, if that's not going to work for you, we could schedule another appointment 2 weeks from now at this time. Meanwhile, he needs his prescription. They would only give us prescriptions sometimes for 1 week or 2 weeks, and they'd say, come back and see me. From their perspective, that's reasonable. From our perspective, it's exhausting my husband, who's in a wheelchair, or who's sick with other things, or who's doing chemo and radiation, and say, okay, do chemo, do radiation, do this, do that, and then show up for this appointment at 3 o'clock. Also, meanwhile, I'm working full-time. And they would schedule these appointments without necessarily consulting me or giving me a lot of options. So these are the things I would wish the medical profession to know. And also a little piece here about what's it mean to be Northern. During that journey of 5.5, 6 years, we had multiple family doctors, at least 3 different family doctors, because they moved away or I don't know what happened. Also, my husband had a different family doctor than I had. So, as a family of 2, it could have been more reasonable to have us in the same place. But we couldn't accomplish that because the doctors weren't taking new patients. For that whole 5.5 years, we couldn't find anyone to
take 2 patients.
To take 2 patients, exactly. So, and then as he got sicker and sicker, honestly, I felt that doctors didn't want to have anything to do, because I asked multiple doctors, with someone so complex, needing complex care. So notice in my, I want to make sure the video is capturing this, the medical industrial complex is on top of my husband here. So from my husband's perspective, and I share this as our story, but I believe this is a very common story, maybe with some slight edits. From my husband's perspective, of course, he's got fear and anxiety and loneliness. He feels helpless. He feels vulnerable. He's got incredible pain. And all of this is going on and on and on. And he has to wait sometimes, like one of our times. The first time, I think, getting the family doctor thought Ken might have cancer, colorectal cancer. So then it's 2, 3, 4, 5 weeks till they get this test or that test. Meanwhile, we're in trauma over this. We have to make maybe some really major life decisions. And that might just be here in the north. I don't know. But the wait between this test and that test escalates the anguish. Couldn't this be done quicker? And I understand the provincial government pays for this stuff, and we're still healing from the conservative government, federally conservative, what's called here liberal, but they were actually almost fascist, in my own opinion. 16 years, I think, they were in charge, and so we have the NDP trying to make it better and more lush, but we're not there yet. Additionally, and this is like hot off the presses. I wrote down the number. Thousands and thousands of people across Canada right now going through this. We went through this before C19. What's happening now, because the hospitals are so burdened with C19, a lot of these things called elective surgery are being canceled. And I saw a man last night waiting 2 years. He's waiting now for his hip surgery, and it's been rescheduled again because of C19. Right? So I just share that if Ken and I had been going through that during this similar crisis, we might have had to wait a year. Meanwhile, he could die from any of those intersecting conditions. From his perspective, he trusts me and he loves me, and I love him and he knows that. But I would want him often to stay in the hospital for another day to make sure they had figured out something. But of course, my beautiful big tall husband, who loves our home and who loves being with me, and of course loves being in his chair, in his fridge, in control of some of the aspects of his life. So he would always want to come home. And at different moments, it caused a lot of conflict between him and me, because you have to stay for more tests, or you have to stay because I can't do this tomorrow morning. I can't bring you for this test or this thing. You have to stay in the hospital. So here's what I would wish doctors to know. Remember to take in the familial and service availability context of your patients. He, of course, wants to go home right now, right? Who wouldn't? But I don't know how to give him new needles for this and that. He had to have 2 needles a day for the diabetes. He had to have different pills with every condition, and the pills had to be, let's say, with food or without food. With the diabetes, we got to figure out the with food, without food. The stoma, the pouch, so many things.
Brain fog.
Brain fog, and he's allergic to pain meds, right? So all of that stuff, if the doctor could say, we can't release you until tomorrow afternoon at 4, or we're not going to release you until the weekend. But when you make that decision, make it with the caregivers. Who's going to be with my husband for these 3 days while I have to work 8-hour shifts? I have no one, right? And again, that's not just my story. This is a very standard story, right? So from his perspective, he's, why does my wife want to force me to stay at the hospital? Doesn't she love me anymore? What, they could put those kind of questions. And he's in constant pain. Another example, we were trying to get cannabis oil for him. And it was just a run around, because it had just been made legal. We ended up having to almost get illegal. Well, it actually was. We got illegal cannabis oil because we couldn't get a prescription. So that meant I was spending $300, $400, $500 trying to get cannabis oil for my husband to manage the pain because he was allergic. Our family doctor refused to write us a prescription. The specialists and the cancer people refused to write us a prescription. So that money came out of our budget, which was right down to bare knuckle bones, right? So again, ask yourself, I guess, what are your risks? Right? And are you as a doctor prepared to ethically take a few risks? And they weren't. So they would prefer my husband be in anguish and moaning nonstop for a year and a half. After the second cancer, he always was in pain. It never stopped. It was just, is it bearable right now or not? If they could take that risk and also consult with the family members and care workers before you tell the client they can come home. One of those times they disclosed him, he let him out of the hospital, and he was walking along on his way home, foggy brain, freezing outside. It turned out he didn't have a key. Fortunately, I drove up just half an hour, 15 minutes, right? The hospital knew all this. I had told them many times, but somehow they told him, oh, you can go home. So he did. And walking home, the slippery, icy winter, this was maybe February, he could because he was shaky, he could so easily have slipped and injured himself again in a really substantive way. And all they had to do was wait another half hour, and I would have been off work. We had arranged all of this, and then somebody dropped the ball. So, from my husband's perspective, he's got these multiple causes of pain and anguish, and these were meant to be like barbed wire. So we have my husband's needs, concerns from his perspective. And here's Ken. And the medical industrial complex is on top. So, I would like you to notice, here I am, upside down, the little caregiver woman who's trying to negotiate all these spaces. And I'm sort of at the end of this piece of barbed wire and wires and string and strange things. I'm upside down. And I want you to see how this works. So medical industrial complex on top, my beautiful vulnerable husband underneath that, and then me thrown out in spaces like this. You see the surgical gloves here too. And this is what my day-to-day felt like. Do you notice how I'm banging on the ground? I want you to really feel that. And what were my embodied symptoms? Because that was what she wished us to express through these art pieces. My blood pressure went up. My clinical depression went up. My ulcers went up. My headaches went up. And here I am now, 7 years after the original diagnosis. And all those ups have been upped again. Because when he died, of course, it was like ruination. I was broken for weeks and months, and I still have. We're now 22 months and 10 days or something, and I still have really, really bad days. Okay? So I wish you to see this whole truthfulness. This is a phenomenological truthfulness from 3 perspectives, and I understand the nurses, the doctors, the surgeons, the specialists, everybody. You all have your own location, but please try to figure out how to network and try and see it from the client's perspective, or your the client not being alone, but be in relationship with other people and resources. And our class issues, the money for all the cabs, there would be one thing where they want him to take a blood test at 8 in the morning, go to the hospital, get a blood test at 8 in the morning, do this, then come home, and some other appointment would have to be at 3 o'clock. So we'd take a cab right back up to where we were, and then home. And we're not far from the hospital, but he couldn't walk. He was so shaky towards the end, right? So couldn't we have scheduled all that together somehow, whatever it is? I know sometimes you can't, but sometimes you could. The other thing is to just ponder, how much will this cost a person in taxis, in childcare? Will she have to take a day off work to accompany him? I am an incredibly privileged person in that I have some benefits, and also I'm quite clever and wise in negotiating all these things. I got good, though it may not appear that way, I have good time management skills. I am able to negotiate and be an advocate. But on the other hand, too, one of these times I was trying to negotiate, I was saying my husband has to stay here for 2 more days because I don't have the resources, and I have to set up I'd like to redo the bed, and there were things I was trying to do. And she said to me, the nurse said to me, if you don't lower your voice, I'm going to call security. And this just, one, shocked me, because I don't think anyone would perceive me as a threat, that you have to get security to take me out of the building. But that was clearly an attempt to shut me down. She wasn't really listening of what it would mean to send him home right now. It just was impossible, and I was feeling so frustrated. And of course I wasn't threatening her with violence, but of course all workers, from their perspective, they don't have to listen to anyone being high-strung or demanding, or, right? I understand from the medical industrial complex perspective, but reflect on this with me, the only person caring for him. And I didn't want him to be alone in the house for, maybe an hour, but he needed his pouch sometimes changed for him. He needed the urine thing taken and changed. He needed his pills in a certain sequence. He needed his diabetes needles. Like, there was a lot going on. We could not just leave him alone for, 8 hours, right? So reflect on all that. Reflect on, this is how a person could feel. I felt suffocated. I felt unheard. I felt overwhelmed. I'm still seeing a therapist. I've always been seeing therapists, but on the issues of grief and helplessness. And again, I'm incredibly privileged to even have that. Reflect on when, and at least 2 times a medical professional said to me very, well, can't you take a semester off work? So to say that in front of my husband, it suggests that, oh no, I'm just being a bitch, I don't love my husband. I just, would rather get the money so I can buy hairspray. Right? It was suggesting we had that choice. And we don't. And I'm way, way more lucky than I would say most people are. They might be just living paycheck to paycheck. And for you to say to the wife or care worker, why don't you just quit your job? It's very offensive, and it breaks your heart, because you think, well, maybe I should just quit my job. But we won't have any food in 4 weeks, right? Or all these medical costs. I could quit my job, but then or I could take a year off. But who's going to pay for all his pills, or to rent the wheelchair, or to take the cab, or all these things. Also, when they flew my husband, by the way, to Vancouver, he was there for 11 days, I think. And we thought he might die. They asked me to sign the papers again and blah, 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 to discuss that. And so that gave me fear of this could be it. So I wanted to be with him in Vancouver. I had no money, right? The plane ticket, hotel room, all the costs, right? I got really lucky. Basically, a woman allowed me, for I think it was $60 a night, to sleep on her floor. I happened to find through a network, through a friend, through a person, a very affordable way to be in Vancouver for those 8 days. And it just worked out. I wasn't teaching. It was, I think, the first week of September. So we got lucky. But again, an ordinary person who doesn't have $3,000 in the bank, not saying I did, but I kind of had credit, that would my husband have died alone in Vancouver? Somebody talked to me about this, right? Somebody talked to me about this. So going back to this as a research, and you've heard way more of my story than maybe anyone wants to hear. How does a person capture all that in one art piece? You're going to have to do maybe a lot. I had some art skills and creativity skills, but ask yourself, if you're doing this as your research mode, do you have all the resources, the words, some technical skills? And Darian has many, a master's degree in art. But that's part of when you do your ethics, when you do your plan, when you do your resource, and your ask. If you're asking too much of people, maybe they won't do it. If you're not giving people the supplies and the resources and the support, the technical skills, oh, this is how you tie this, or this is how this could work. Darian had actually a staff member who has tons of artistic experience and skill from Two Rivers Gallery. I'm not sure how she figured that out, but so all 5 sessions there is a support person who has brilliant artistic skills, right? As a student with an MSW, are you building in enough of that support, right? So this is the 3rd task we had to do, and I think I haven't finished it. I had hoped to have it finished for today. So we had the little booklets we make for everyone else. We have some other art thing that displays our symptoms, and here I am with my symptoms. And then the 3rd task was to imagine a conversation, and she's asked us to imagine a specific conversation between a healthcare professional. So this is, let's say, me. No, I'll say the blue is me because I'm sad, and the healthcare professional is here in white, the clinical, to match this, the white. Then she helped us make these cool little books. And so the conversation is supposed to unfold page by page, right? And she's asked for one specific moment. And then the nurses, doctors who are going to watch this art display or videos or however she's going to eventually multi-layer it. It might also be, I believe it is, a research project, a report. So she'll have multiple deliverables or outcomes, because your people may ask you that on your committee. What's the deliverable? What's the outcome? What's the final goal, right? She had these, and then she's bringing it to the healthcare professional. So, again, I'm very verbal, and I'm very creative, and I love to put words on the screen and I have the computer. So for me, this is going to be very cool. That's part of why I've delayed it, because I want it to be good. To say, in my particular case, I'm going to describe the moment I just described to you about, well, can't you quit your job or take a year off? Or, I'll describe in other minutes that I haven't written in here. They would discharge him sometimes at 9 o'clock at night, 10 o'clock at night, because this, remember, it's constant. I don't know, 80 times he was in and out of the hospital for all these things. I don't know, maybe another, I don't even know, 3 times a year, 25 surgeries, 30 surgeries, and that's just the cancer stuff. Then there's the chemo appointments or radiation appointments. So I would kind of tease sometimes. I had my full-time job of taking care of my husband, and I want to do it because I adore him. But I still have to make money because I adore him. Do we want us to have no money for medicine or food? No, because I love my husband. So, making that absolutely clear. So I'm going to put a couple of those different moments into, she asked for one. I'm going to put a few more. And I believe she's celebratory of me doing that.
Mm-hmm.
Right? So that's perfect. Her response to my request, can I do this? That's what I wish you to do to your participant. And I'll just finish that other example of how it was distressing for me is they would let him out of the hospital. They would say, you have to come get your husband. He's discharged tonight at 9 or 10. Okay. Then they would say, he has to take this and this pill in the morning and one of these before bed tonight. Has to be taken with food or without food. And I might have to go to work at 8:30 in the morning. Note, the pharmacy is closed. So saying, go get these pills for your husband is putting me in a shitstorm of crisis, because all the pharmacies are closed, and in the morning I have to be at work at 8:30. That means I have to be on my way to work at 8. The pharmacy doesn't open till 8:30 or 9. Am I going to have like my magic unicorn show up and go to the pharmacy and get this stuff and then bring it home to my husband and make sure he's got, right? So I would also say structurally, and maybe I'll conclude with this point about my voice, my commentary as a research participant. I would want to say that you need to see the whole person, their whole context, everything that's going on for them and their caregiver. Ponder their gender roles, and are you reproducing sexist, misogynist, bullshit, impossible expectations on the caregiver, and doing the speaking work to the patient rather than also dumping that onto me. Oh honey, you have to go to the doctor, because it's me. He often would feel that he would get to the hospital and he'd say things like, my wife overreacts, or my wife's a hypochondriac, or my wife is super sensitive to these things because she's a social worker. And then they would say, oh, later I'd find out, oh, if you hadn't come in with this sepsis in the ambulance and that, you would have died a day later. Right? So at least 3 times they said to me and him, somebody said, if your wife wouldn't have done this, you would have died. So the next time he's in confusion or he's in great pain or whatever, and I call the ambulance, I'm thinking, I'm worried he's going to die. Right? And he'd be thinking, I don't want to go to the hospital because once I get there, they might keep me there. I would rather be at home with my wife. And so that's it. The medical profession would be saying, well, we should check his heart. We should check his this. Is this as is appropriate in the emerge? They would do all those good things. But it would be a different nurse, different doctor. He's in a space where there's 10 other people. He wants to come home. So you medical professionals, you need to say to him, we can't let you go home. We're worried about you, and we want you to get the best care possible. If you go home, your wife doesn't have the skills of a surgeon or a doctor or a diabetes specialist, right? Don't put it all on me, because towards the end, he more than once felt that I was just trying to ditch him at the hospital. wasn't. I never was. And it breaks my heart that anyone would even think that. So, and I'll ask you medical professionals, if it was the exact opposite, if it had been me who had all these illnesses and my husband had an excellent job trying to make money, would you have said to him, why don't you quit your job to stay home and care for your wife's diapers and food and cleaning and meals and needles and pills? Would you have said that? I'm not sure you would have.
Mm-hmm.
I think people still assume it's the wife, it's her role, and don't you love him? If you love him,
You'll support him.
you'll support him by quitting your job. Well, I'm supporting us by paying the hydro bill, right? And all these fancy pills and things, which I wanted to do, but there was more than one time where there were disappointments, this specialist and so on, and I'm responsible to be with 30 students in a classroom in exactly that same time slot. I can't be in two places at the same time, right? Boom, and I have privilege. But imagine a woman who's working at Tim Hortons. She can't say, oh, I'll be half an hour late, or ask one of my master's students, could you open the class and plug in a video? I'll be there 10 minutes late, right? If she doesn't show up for her job on time, maybe 3 late, and she's fired, right? Reflect on all this stuff. Your time is important, but so is mine. And so is my husband's, who knew he had only at the third diagnosis, we were told 2 years to 6 months, between that range. So we knew we didn't want to waste a day sitting in the specialist's office. And also sometimes he would almost pass out when they say, come at 3 o'clock. See us at 3 o'clock. Don't see us at 4:30. Right? So again, thank you. I wanted to share this research thing, this video for medical professionals. Us as researchers, people who are doing their master's in social work, their gender studies, or other research projects I've been involved with in other disciplines, go for it. Use the art. I think it's powerful. This kind of stuff from 10 or 20 or 30 or 50 people who've used the medical care system for various, cancer, head injury, MS, there's quite an array of people who've consented to be part of this. I think that's wonderful. I think she's doing the transition work, Darian, as a researcher between the nurses, doctors, dentists, pharmacists, specialists, and us, the patients. And I guess the arts community too, because that's how she's being a curator of all of this material. So she's not going to just do a degree or a thesis or a document. She's also going to curate art displays, and I would imagine a video. Go on her site. You'll see she's got cool videos on other things. So do you feel I've covered everything?
I think so.
Carlene is my tutor sometimes. Am I being clear? Thank you for watching this. Please consider using art-based research. Thank you to Darian for inviting us to be part of such a thing. Thank you to her for doing what I think is quite courageous at this time. Not everybody's going to take the risks of doing such complex layering and layering. Thank you to Two Rivers Art Gallery. Thank you to everybody involved with the project. And use your creativity. Whatever it is you're doing, use it. It's one of your superpowers. Don't be afraid.